Okay, let's unpack this. You know how sometimes the body feels like this incredibly complicated puzzle?
Oh, absolutely. It really is.
Well, one of the most critical balancing acts it performs is managing its acid-base state. And today, we're doing a deep dive into one specific way that balance can get thrown off: metabolic acidosis.
That's right.
We've gathered quite a few articles and notes on this.
You have a good stack.
And our goal here, really, is to give you the essential information, like a shortcut, to understanding what it is, how it happens, and crucially, how this thing called the anion gap helps figure out the cause.
Exactly. Metabolic acidosis. It sounds a bit technical, maybe,
Oh.
but it's fundamental. If you've ever heard about pH balance, well, this is a major way it can go wrong. We'll walk you through the definition, the causes, the signs, and how doctors use that anion gap, like you said, as a kind of detective tool.
So by the end, you should have a pretty clear picture.
That's the plan, a solid framework.
Great. So let's jump in. Based on the sources, what is metabolic acidosis fundamentally?
Okay, so at its core, it's a state where the blood becomes too acidic. Clinically, that translates to two key things: a low blood pH, so below the normal range, and also a low level of plasma bicarbonate.
Ah, bicarbonate. That's the body's main buffer, isn't it? The thing that sort of mops up excess acid.
Exactly. Think of it like the body's built-in antacid.
Yeah.
So with metabolic acidosis, you've basically got one of two problems happening. Either you've gained too much acid, specifically hydrogen ions, H+,
Yeah.
and it's overwhelming that bicarbonate buffer.
Okay.
Or you've lost too much of the bicarbonate buffer itself directly.
So too much acid added or the buffer disappearing. Got it.
Either way, the result is the same. Blood chemistry shifts towards being too acidic.
Right. And this seems to be where our sources really zero in on this diagnostic tool, the anion gap. Why is calculating this gap
Yeah,
so important here?
because it's the key. It's the detective tool that helps you distinguish between those two main scenarios we just mentioned.
Gaining acid versus losing buffer.
Precisely. The anion gap helps you figure out which one is driving the acidosis. Put simply, it's the difference between the main positive ions we measure in the blood, mostly sodium, and the main negative ions we measure, chloride and bicarbonate.
But wait, shouldn't the positive and negative charges always balance out overall in the body? Where does a gap come from?
That's a great question. Yeah,
Yeah.
they do balance. The gap really represents the negative ions that we don't routinely measure.
Oh.
Things like phosphates, sulfates, proteins, especially albumin, and importantly, the negatively charged parts of certain organic acids. Normally, these unmeasured anions account for a small, pretty consistent difference.
Right.
But when certain things go wrong, especially when specific types of acids build up, the concentration of these unmeasured negative charges can increase quite a bit.
I see. So if bicarbonate drops because it's busy buffering an incoming acid, these other unmeasured negative ions increase to kind of fill that charge void, electrically speaking, and that's what makes the calculated gap wider.
You've got it exactly. So calculating the anion gap isn't just, an academic exercise. It's vital for investigating metabolic acidosis because a high gap points towards one set of causes.
Accumulating acid.
Right, while a normal gap points towards another set.
Losing bicarbonate, mostly.
Exactly. It's that critical first step in figuring out the why.
Okay. And the sources mention the calculation. Sodium minus the sum of chloride and bicarbonate. Normal is around 8 to 12 milliequivalents per liter, usually without potassium in there. That's the common way, right?
Yeah, that's the most standard calculation used clinically. And a gap above, say, 16 MEQL is generally flagged as high.
Over 16. Okay, that's the number to watch.
That's often the trigger, yeah. It tells you which paths to start investigating first.
All right, so let's explore those two paths then. First up, what's going on when someone has metabolic acidosis, but the anion gap is normal?
Okay, so a normal anion gap metabolic acidosis. This usually happens when the body is losing bicarbonate directly, not through the kidney's usual acid handling, but from somewhere else. Or sometimes it's from gaining too much chloride relative to sodium.
So the problem isn't a buildup of some new weird acid. It's more like the existing buffer supply is just leaking out.
That's a good way to put it. The buffer is being lost, and chloride ions often increase to take up the electrical space left by the bicarbonate, which keeps that calculated gap in the normal range.
Losing the buffer directly, where from? What kind of examples did the sources give for this?
Well, the classic textbook example is severe diarrhea. You lose a lot of bicarbonate-rich fluid from the gut.
Makes sense.
Other causes could be things like lower intestinal fistulas that drain fluid, certain types of urinary diversions where urine bypasses the bladder, Some diuretics can do it, early kidney problems where the tubules aren't reclaiming bicarbonate properly, or even getting too much chloride, like from large amounts of normal saline IV fluid. Sometimes even IV nutrition, if it doesn't have enough bicarbonate precursors.
Okay, so normal gap equals buffer loss, primarily. Now, what about the flip side? High anion gap metabolic acidosis. This is where the gap widens.
Right. This type happens because of an excessive buildup of specific acids in the body. And these aren't just any acids. They tend to be strong acids that, when they dissociate, release both hydrogen ions, H+, and their corresponding negatively charged base, the unmeasured anion.
And that's the key to the high gap, those leftover negatively charged bits that aren't chloride or bicarbonate.
Exactly. The H+ gets released, bicarbonate jumps in to buffer it, so bicarbonate levels drop. But the other part of the acid, think lactate or ketoacid anions, these just accumulate in the blood. Since we don't routinely measure these anions, their buildup creates that larger difference, that wider gap between the measured positives and negatives.
Okay, that clicks. The high gap is literally showing the presence of those extra unmeasured acid anions.
It's like their
Oof.
fingerprint left at the scene, yeah. It tells you which type of problem you're likely dealing with.
So what conditions lead to this kind of acid buildup and a high anion gap?
This points you towards a specific list of often quite serious conditions. The sources mention things like lactic acidosis happens when tissues aren't getting enough oxygen.
Like in shock.
Exactly. Shock, severe infection, intense exercise sometimes. Also, salicylate poisoning, that's aspirin overdose. Kidney failure is a big one because the kidneys can't get rid of the normal metabolic acids.
Right.
Then there are poisonings from things like methanol, ethylene glycol, that's antifreeze,
Oh, wow.
propylene glycol, and then diabetic ketoacidosis, DKA, a major complication of diabetes where ketone bodies, which are acids, build up. And similar ketoacidosis can happen from starvation or severe alcoholism.
So that anion gap calculation is incredibly powerful then. It really helps narrow down the possibilities.
Immensely. It's a crucial fork in the road.
Okay, so someone has metabolic acidosis, low pH, low bicarb. What might you actually see in a person? What are the clinical signs, the symptoms?
Well, it really varies with how severe it is. For milder acidosis, the symptoms can be pretty vague, actually. Things like headache, maybe some confusion, feeling drowsy, nausea and vomiting are quite common too.
And what about breathing? You mentioned the body tries to compensate.
Yes, absolutely.
Yeah.
The lungs play a key role. The brain senses the increased acidity and triggers the respiratory system to work harder, breathe faster and deeper. We call it hyperventilation, or sometimes Kussmaul respirations if it's very deep and labored.
And the point of that is?
To blow off carbon dioxide, CO2. Because CO2 combines with water in the blood to form carbonic acid, getting rid of CO2 effectively reduces the acid load and helps nudge the pH back up slightly.
It's like the body's trying to exhale the acid, in a way.
That's a perfect analogy.
Yeah.
It's a really important immediate compensatory mechanism.
But it might not be enough if things are really bad.
Exactly. If the acidosis gets severe, say the pH drops below 7.0, which is very acidic, then you start seeing much more dangerous signs.
Like what?
You can get peripheral vasodilation, blood vessels widening near the skin. This can cause blood pressure to drop, potentially leading to shock. The heart function itself can be depressed, leading to decreased cardiac output. And critically, there's a high risk of cardiac arrhythmias, abnormal heart rhythms, which can be fatal. The person might look pale, feel cold and clammy.
That sounds serious.
It is very serious.
And the sources also brought up chronic metabolic acidosis, particularly with chronic kidney disease.
Yes, that's a really common scenario. As kidneys fail over time, they progressively lose their ability to excrete the acid that's normally produced from metabolizing food, especially protein. So acid gradually builds up, leading to a persistent, chronic state of metabolic acidosis.
Okay, so how do clinicians nail down the diagnosis? How is it assessed?
The gold standard test is the arterial blood gas, the ABG. That gives you the direct measurements of blood pH, the partial pressure of carbon dioxide, PCO2, and the bicarbonate level, HCO3.
And for metabolic acidosis, you're looking for that low pH, and the sources kept saying the cardinal feature is low bicarbonate.
Absolutely. A bicarbonate level below the normal range, usually under 22 MEQL, combined with a pH below 7.35, that's the signature of metabolic acidosis.
What about potassium? There's a lot in the notes about potassium shifting around.
Ah, yes, that's incredibly important clinically. What happens is, in acidosis, there's an excess of hydrogen ions, H+, outside the cells. To try and buffer some of that acidity, H+ ions move into the cells.
Okay.
But to maintain electrical balance, as positive H plus moves in, another positive ion has to move out. And that ion is usually potassium.
Okay.
So potassium shifts out of the cells and into the bloodstream.
Leading to hypotassium in the blood hyperkalemia during the acidosis.
Correct. You often see hyperkalemia when someone is acutely acidotic.
Ah.
But here's the crucial part for treatment. When you start correcting the acidosis, the process reverses.
Oh.
Hydrogen ions move back out of the cells, and potassium moves back in. This can cause the blood potassium level to drop, sometimes quite rapidly,
Oh.
potentially leading to low potassium hypokalemia as the acidosis resolves.
And that sounds risky given potassium's role in the heart.
Extremely risky. Both high and low potassium can trigger dangerous heart arrhythmias. That's why the sources stress the need for close monitoring of potassium levels, often with ECGs as well, during the management of metabolic acidosis.
Right, makes sense. And the ABG, does it show that lung compensation we talked about? The faster breathing?
Yes, it does. You'll typically see a PCO2 level that's lower than normal in the ABG. That reflects hyperventilation, the body blowing off CO2 to fight the acidosis.
Right.
And there are even formulas clinicians can use, mentioned in the notes, to calculate the expected degree of respiratory compensation for a given drop in bicarbonate. That helps them see if the lungs are responding appropriately, or if maybe there's a second coexisting respiratory acid-based problem too.
Wow, okay. So the ABG really tells a detailed story. So once it's diagnosed, and maybe the anion gap has pointed towards a cause, how is metabolic acidosis actually treated? What's the management approach?
The number one principle always is to treat the underlying cause. That's paramount.
Right.
So if it's DKA, the treatment is insulin and fluids. If it's methanol poisoning, you give the antidote, fompazole, and maybe dialysis. If it's caused by massive fluid loss from diarrhea, you replace the fluids and electrolytes and maybe give bicarbonate. If it's due to getting too much chloride from IV fluids, you stop those fluids.
So fix the root problem first. What about giving bicarbonate itself? Is that always done?
Not necessarily. The sources are actually quite cautious here. Bicarbonate therapy might be used if the acidosis is severe, say pH below 7.1, or if there are severe symptoms. But it's not automatic.
Why not?
Well, there are potential downsides. It can cause fluid overload because it's given with sodium. It can worsen intracellular acidosis in some situations. The notes specifically mention caution during cardiac arrest, where it might paradoxically make things worse inside the cells. And it can also drive potassium into the cells too quickly, worsening hypokalemia.
Okay, so it's used judiciously.
Very much so. And again, managing that potassium level throughout treatment is absolutely critical, anticipating the drop as acidosis corrects.
Great. Treating the hyperkalemia first, then being ready for hypokalemia.
Exactly. Monitor, monitor, monitor.
What about the chronic metabolic acidosis, like with kidney disease? Is the treatment different?
Yeah, for chronic cases, the goal is more about long-term buffering. Patients might be prescribed oral alkalizing agents, like sodium bicarbonate or sodium citrate, to neutralize the daily acid load that their kidneys can no longer handle.
Okay.
There was also a specific point in the sources about treating chronic acidosis. You need to make sure the patient's calcium levels are adequate before giving bicarbonate.
Why is that?
Because as the acidosis corrects and pH rises, more calcium binds to albumin, reducing the active ionized calcium level in the blood. If someone is already low on calcium, this rapid drop can trigger tetany, painful muscle cramps and spasms. So you fix the calcium first, then the acidosis.
Good tip. And for severe chronic cases.
If oral agents aren't enough, or the kidney failure is advanced, then dialysis, either hemodialysis or peritoneal dialysis, becomes necessary to remove the excess acid and restore balance.
Wow. Okay, we really covered a lot of ground there. From just the basic definition, low pH, low bicarb, all the way through using that anion gap as a detective.
Yeah, differentiating buffer loss from acid gain.
Understanding how the body tries to breathe it off, the symptoms, the potassium shifts.
And focusing treatment on the root cause while managing those tricky electrolyte changes.
You've definitely had a deep dive into a pretty complex area. We've seen metabolic acidosis is that low pH, low bicarb state. The anion gap is that crucial tool telling you why losing buffer or gaining acid. Symptoms range from vague to life-threatening. The lungs try hard to help, and treatment targets the cause, keeping a very close eye on potassium.
That sums it up nicely.
It really underscores just how intricate the body's balancing acts are, doesn't it? And what strikes me most, thinking about it now, is how a calculated number, the anion gap, just the difference between some measured ions, acts like such a powerful clue, almost like a fingerprint left by the specific disease process.
It really is a fantastic example of that.
It makes you wonder, what other subtle chemical signals is the body constantly sending, and how decoding these complex interactions is just fundamental to understanding health.
Absolutely. The anion gap is just one piece, but it shows how much information can be packed into seemingly simple measurements about the body's internal world.
Definitely food for thought.